welcome to the Road to Genome podcast. This episode is being brought to you jointly by the Genomic Medicine Services in the North East and Yorkshire and the East of England. I'm your host, Helen Bethel, Genetic Counsellor and NEY Workforce Development and Education Lead. Today we come to you from the School of Clinical Medicine, part of Addenbrooke's Hospital in Cambridge. I'm delighted to be joined by Chris Hind, Chair of the Patient and Public Voice Forum here at the East GMSA. Hi Chris, thanks so much for joining us. Can you tell me a little bit about your professional or personal journey that has eventually brought you into the world of genomics?
Okay, so if we go back to 2018, I was diagnosed with Haemochromatosis, something I'd never heard of. And it was almost a freak diagnosis because I had a persistent chest infection and my GP very wisely asked for a blood test. The results came back. He spotted immediately that my iron levels were through the roof. So he made a referral to a haematologist at my local hospital, the Norfolk and Norwich. And I got to see him, I think, within 2 weeks. And he explained what haemochromatosis was all about, what the treatment plans would be. And so immediately I started a process of giving blood every week, which they call venisections, which is a posh word for bloodletting, since the NHS stopped using leeches. So I had to go every single week for just over a year to give a pint of blood to get my iron levels down to where they should be. And fortunately that worked. So after diagnosed, I was also given a pretty full MOT. With haemochromatosis, the iron has to go somewhere in your body if it can't get rid of it. So it tends to stick itself to your heart or your liver, your kidneys. So I had, lots of scans and investigations to make sure I was okay. And in my case, I did have slight cirrhosis of the liver, where the surface of the liver had been damaged by the iron. So I have regular 6-month ultrasound scans just to make sure the liver has not deteriorated. Unfortunately, it seems to be fairly stable.
Oh, that's good to hear. Did you experience any other symptoms?
No, not really. And interestingly, I didn't have any symptoms I was aware of at the time, although people tell me I was a little bit red in the face, which is quite common apparently with patients who haven't been diagnosed. I suppose I was suffering a little bit of fatigue. I just put it down to age. So, started having the odd siesta in the afternoon, which is something I'd never ever done. But so that was my initial diagnosis. And obviously I spent a lot of time in the hospital and I was beginning to think, well, actually I could do things to help here. I can see what's going on, why they're sending out letters on paper, why all the nurses gathering around there. And so I initially volunteered to be out on the patient panel at Norfolk and Norwich, did that for about a year. And I was also elected as a public governor for the hospital, which I'm now in my 4th year as a public governor. So that got me more involved in the hospital and the running of the hospital and gave me the opportunity to sort of delve a bit deeper and obviously work closely with the board of directors and the non-exec directors to help, try and improve the services for patients in the hospital. And I guess after about a year of being a public governor, I was approached by one of the clinicians involved in genomics who said that, we are trying to start up a patient panel. Would you be interested? So I kind of said yes. And, almost immediately I had to then go and recruit a panel, which was great. So that's really how I got into the world of genomics, from my initial diagnosis to wanting to try and do more to help the NHS and my local trust. And it also coincided with me retiring from my professional life. So I'm not a medic. I've got no scientific or medical background. I spent 30 years working in financial services and investment management. So NHS is all very different, but it's something I feel passionate about and want to try and improve the patient lot.
And was it your genomics health journey that kind of intrigued you and interested you into the hospital environment? Or was that just...
No, very much so. I think, when you are a patient and you're under different departments in the trust, you see lots of aspects of how the hospital works and how some of it doesn't work so well. So that sort of gave me an interest and a passion to try and help improve that. but also with rare diseases and, going into the haematology department every week, which is also next door to the cancer care. You see, really sick patients having to come in for their weekly oncology sessions. It's quite mind-blowing, really, and humbling as well. So I just felt, I could probably do a little bit to help in a small way.
Yeah, that's great to hear that you were so motivated to help in such a positive way. Just going back to your diagnosis, how different was that from a general medical diagnosis to receiving a genetic diagnosis?
I suppose initially I didn't fully appreciate that it was a genetic diagnosis or a rare disease, although, I subsequently learned it was a fairly rare disease. I think haemochromatosis is about 1 in 100 patients in the UK, so many GPs never come across it in their working lives. But fortunately mine had come across it and did spot it. But I think I just wanted to sort of get more involved and try and help and, improve the patient pathways. And fairly soon after I was diagnosed with haemochromatosis, obviously all my family, siblings and cousins had the same test to establish if they'd got the same defective gene, which 2 of them have. And interestingly, my sister who lives in London had a very different experience because it took her GP 3 attempts to actually correctly diagnose her. And that took her about 9 months, whereas I got it done immediately. So I think there's a bit of a postcode lottery as to how quickly you are diagnosed. And also going ahead a couple of years to 2021, my other sister who lives in Norfolk was diagnosed with breast cancer, and she was recommended to have genomic testing. And that confirmed she'd got the presence of the faulty BRCA2 gene. And then obviously me and my other sister in London had to go and have genomic testing and counselling to discover if we've got the BRCA2 gene, which in my case I have, which means I'm twice as likely to get prostate cancer as someone who hasn't got the faulty BRCA2 gene. And that's why last year I volunteered to go on a research trial at Royal Marsden for prostate cancer. So I'm sort of helping myself, but also helping the patient group with prostate cancer to try and learn more about it.
Sorry to hear about your sister and obviously the subsequent diagnosis for yourself of that BRCA2. Can I ask you, so the BRCA2 testing, I'm assuming, was that within clinical genetics?
Yes. Yeah. Yes.
And your testing for haemochromatosis was in a more mainstream secondary care setting. Can I ask you, how did those 2 experiences compare?
They are different. Obviously, the working life of a GP is very different, and they're obviously under enormous pressures post-COVID. I mean, my test was done pre-COVID, but I think, when you sit in front of a GP, you've got a limited period of time to talk to him. But if you have an appointment with a haematologist or an oncologist, whoever it may be, as a specialist, you've probably got, again, limited time, but you're having a more detailed, in-depth discussion. And I should give a plug for Haemochromatosis UK, because they have got an excellent website, and I was pointed towards that by the haematology nurses and the haematologists I saw. And there's a wealth of information on that site to help patients as well as professionals.
Yeah, fantastic. And in terms of your experience through clinical genetics, I'm assuming, was it a genetic counsellor that you maybe saw to take you through predictive testing? How did that compare? Because in a clinical genetics, we're in a predictive setting, we generally tend to give a little bit more time and consideration to that kind of consent process of having testing for a genetic diagnosis. Did that differ in any way, do you think, from your diagnosis of haemochromatosis and your testing around that?
I think, I saw a genetic counsellor in Norwich who'd come from Cambridge. She was very good, explained everything very clearly, and had a lot more time to answer any questions that I may have. But I just said, right, I want the test. Let's get on with the test. I was kind of impatient to get it done and get it in the system. But no, she was very caring and very thorough.
Yeah, great. How did it feel sharing your initial haemochromatosis result with the rest of your family?
Well, I suppose initially I wasn't that fazed about it and didn't probably fully understand the implications long term. I guess once, I'd gone through 6 months of venisections, and my sister had been tested herself, and she had confirmation that she had got to do the same thing and go through the bloodletting. Yeah, it sort of became more real, more serious. And certainly when I was having, my MOT, as I call it, gastroscopies, colonoscopies, heart investigations, all these things, I thought, crikey, what's going on? I don't feel ill, but they're sort of checking that I'm okay. That was a little bit daunting, I suppose.
So was your diagnosis for haemochromatosis the first time you'd heard of genetics or genomics?
I suppose it was the first time I'd heard of genomics, but I'd heard of genetics.
Yeah.
And, it's getting your head around what's the difference. And I guess looking back, you think, well, if I've got this and my sister's got it and one of my cousins has got it, who else in the family has had it before? So the haemochromatosis is often described as the Celtic curse. So I'm half Irish, so I've got lots of Irish relatives across the sea, and it's quite likely that's where it came from.
Yeah.
And I think looking back and talking to my mother, who's still going strong at 92, she can remember her parents and grandparents and uncles and aunts. A lot of them died early, probably misdiagnosed, and quite possibly had haemochromatosis.
Can you tell us a little bit more then about your patient and public voice role?
So, having been persuaded to start a new patient panel for the East Genomic Medicine Service Alliance, I was sort of first tasked really to recruit people, and I wanted to make sure that we covered as far as possible, the entire area, because it's quite a big geographical patch, and also with people who'd got personal lived-in experiences of some rare disease or had genomic testing. So those were the two sort of criteria I was looking at. We had a lot of interviews with people who didn't quite fit the profile of what we were looking for, but we had some fantastic people come forward, said, right, yeah, must have you, you're just what we're looking for, and you're passionate, like I am, about helping NHS and learning about genomics and how we can improve the patient pathways. So it was a fairly straightforward but lengthy process, and then people have come and gone for various reasons, like their health may have deteriorated, so we had to recruit some more. But I think now we've got a very strong, well-balanced group of people who are passionate about genomics and healthcare, and trying to improve patient pathways, and also the whole of genomics, how that can help with healthcare in general.
Great. So can you tell me more about maybe one of the projects that the PPV has been involved in, maybe overseeing or inputting to?
Well, we've been involved in quite a few projects. I mean, we were, thrown lots of projects when the panel was established. So I'll give you two examples. So in Norfolk, there was an FH project, which was, if you like, a bit of a pilot for the whole country.
And that's familial hypercholesterolemia. Yeah, that's right.
So that was run by a couple of people in the Norfolk and Norwich, a scientist and a nurse, and it was rolled out to all the GPs. So I think the PPV got involved in trying to promote it with their own GPs and talk about it a lot. And the project only ran for about a year, but it was very successful in identifying a huge number of patients that had FH and needed treating, which had obviously previously gone undiagnosed. And unfortunately, there hasn't been funding to continue it in its form it started off with, but I'm hoping it'll sort of get going again, because it had really tangible benefits for people with heart disease, and even younger people in groups of families in sort of outlying parts of Norfolk. And the other thing which we got involved with fairly early on was pharmacogenomics as a working group, and looking at DPD testing and looking at the patient pathway for cancer treatments. And we are currently sort of working on that as well, to try and improve, if you like, the patient odyssey. So one of the pharmacists is really passionate about it as well. He wants to see how we can improve patient pathway from diagnosis to treatment, and to make that much more quick.
They sound really interesting project.
I've just given you sort of the basics of it, but it's quite in depth, and it does blow your mind how clever some of these people are, especially the scientists.
Yeah, and we can put some links on our website that link to these projects if people want to know more. So thank you for dipping our toe into those. With your PPV hat on, or even as a patient, when we think about the introduction of genomics, particularly in secondary care and primary care, we might have nurses and doctors that might be looking to introduce genomics into their practice where they've not used it before. What advice would you give to those clinicians that are starting to use genomics?
Well, I would say they should embrace it fully. And why haven't they been doing it before? I mean, I've had conversations with quite a few consultants who've, just got into the world of genomics, and they think, why haven't we done it before? They can see the benefits long-term and medium-term and short-term. And it's a fascinating world. And I really do believe it is the future of healthcare. So the more people who know about it, the more people who are involved in some form with genomics, the better, really. So that's going to improve the NHS and the sort of some of the funding issues it faces today. Well, genomics is kind of like going to save money in the future, not right now, but it will improve patients' lives immediately.
Yeah, I hear you with that. I think that's part of the challenge, is that further down the line, you can see how much this will save in, appointment times and unnecessary treatments and, those kind of targeted managements and screening. But I guess we're kind of still in that change round in terms of thinking of that forward thinking of the implications further down the line, and at the moment it's still almost an extra to what people are already doing. So we're well aware of the challenges that mainstream clinicians face when they've got a very short appointment and already have a lot to cover in those appointments with patients, that this is almost asking for more. But in reality, in future, we hope that clinics won't be as full because we'll have more pre-symptomatic people that are coming in for screening rather than being symptomatic.
Rather than treating the problem when it's too late.
Yeah, exactly. So.
Yeah, no, very much so. As I say, with the financial challenges every trust faces, and the NHS in general, everyone's sort of trying to cut budgets and watch where the money goes. I think, if we can get consistent funding through genomics and the projects we're doing now and have been involved with nationally as well as just in the East, that's going to make a huge difference. There's going to be some massive long-term benefits. So if you can, get people to have the mindset of thinking 5 years ahead instead of 1 year ahead. To see the financial benefits as well as the health benefits, which is obviously what we're here to do. Improve patients' lives. It's massive. It really is. So, I've spoken at national genomic conferences, and I think it's very important that we try and get, the politicians involved and to really understand it, because we've had God knows how many health ministers in the last 5 years. We might have the same one for the next 5 years, possibly, but, they really need to be on board and fully understand. And so the work that the Genomics Unit is doing and also Genomics England Limited is really important. And you've got to get all the key stakeholders involved to really understand and embrace the whole genomics world.
Yeah, I agree. And it feels almost like we're almost in a sandstorm at the moment, that you can imagine in 10 years' time that sand will have settled, but it's still not quite clear where all that sand will lie. For example, you touched on the pharmacogenomics. Will that lie with the pharmacists? Will it lie with the GPs? Will it start with a test at birth that, it gives a profile of drug interactions? It's still not clear where all these will land. And come 10, even 20 years time, it will have all settled. But it's at the moment, like you described, it's kind of, getting clinicians to bring that on board and bring it into their practice where it's going to be most effective.
And I guess that's really, what the generation study is all about. To test newborn babies with, I think, is it 230 odd conditions rather than the 8 which they're normally tested for when newborns with the heel test. So that is a longer term project. I think it's going to happen over the next 2 years once they've got the numbers involved. And I can see a situation where maybe in 5 or 10 years time, we all carry a credit card which has got our DNA profiling on it. So everyone knows what's wrong with you or what your conditions may be and how to treat you. So I suppose in a very basic level, that sort of coming to fruition a little bit with the shared care record through electronic patient records in GPs and secondary care. The digital revolution is beginning slowly.
Yeah. So for you, what is the most rewarding part of your PPV role?
I suppose the most rewarding part is dealing with the actual patient panel themselves, because they've all got their own individual stories and journeys, and how we can make an impact to make changes right now and see that come to fruition. So, for example, there was an app developed for Lynch syndrome, and one of my previous patient panel members was a Lynch syndrome patient herself, and she did a national survey which was really successful and helps to understand what the issues are for patients so that clinicians can see it from the other side. And the patient app, which was launched I think earlier this year for Lynch syndrome, again, it's very informative, and it gives more direct contact between patient and genetic counsellors and nurses and also clinicians. And I think that's very important when you've been diagnosed with quite a serious rare disease. You need that support, and that's what that can give you.
Yeah, that's fantastic. That's great. And on the flip side, what is the most challenging bit, would you say, being a PPV chair?
What's the most challenging bit? Well, I suppose the sheer volume of projects. It's knowing which ones to focus on and try and make a difference. There's a lot going on, so we can't be involved in every single one, but it's knowing which are the ones where we can have an immediate impact. And I think also, I would say, just having that regular contact and dialogue with the clinicians that are involved in the projects and getting them to understand our point of view, and not to lose focus of the patient, which sometimes they do because they're so involved head down with their work, and certainly the scientists, they forget as a patient at the end of all this.
Is that what drives you, would you say, knowing the patient at the end of it?
I think we can all improve the patient a lot, and I guess I'm just trying to do my bit and having a good group of people around me and talking to the right people and just trying to get a response.
Looking to the future, what would you say is the most exciting bit or project that's coming down the lines?
That's a tricky one. There are so many to choose from, and they all have an impact. But I would probably say a lot of the cancer studies, there's a lot going on here in Addenbrooke's, various cancer studies, and you can see when there's a breakthrough how incredible that is and what the impact is for patients. I can't give you any specific examples, but there's a lot going on, and it's almost too much to take in.
Well, maybe one of them that you're probably aware of is, and it's happening nationally, is that for prostate cancer and solid tumour testing.
Yes, ctDNA testing for lung cancer,
For the lung cancer, but also for prostate cancer with the testing of BRCA1 and BRCA2, which helps inform treatments, but also for patients such as yourself where maybe there hasn't been a discovered family history before, it can sometimes highlight patients. So I wasn't sure if you were aware of that project or not.
I am, and that's one reason I joined the research trial at the Royal Marsden. So I had blood tests, and they have their PSA scale, which is slightly different to what GPs use, and I had an MRI, and they sent me for a biopsy about a month ago, which fortunately was all clear.
It's great.
But obviously there were sort of one or two little question marks about that because of my sort of raised PSA level and something that came up on the MRI they weren't sure about. So all those kind of studies I think are invaluable and really can help. Yeah,
of course.
Because it's quite scary when someone says, well, there's a very high chance you might get prostate cancer in the next 10 years compared to someone else. The more that you can get involved, help and understand it and be part of these trials, I think is great.
Yeah, fantastic. So where would you like your ambition to take you next?
Well, that's a very good question. I suppose just to keep talking genomics, both regionally and nationally, and to have those continued discussions with the key stakeholders and people involved in healthcare and with politicians and even local government to make sure we get the right support and the money for all the fantastic work which is going on.
Fantastic. Well, thank you so much for joining us, Chris.
Thank you, Helen.
Fantastic to hear your story.
Thank you.
Thank you for joining us on the road to Genome. If you would like more information about the topics and conditions that we have discussed today, then you can find these on both ney-genomics.org.uk/podcast and eastgenomics.nhs.uk. Here you will be able to find all the episodes in our podcast series, or alternatively they can be found on Spotify, Apple Podcasts and all other major podcast platforms.